anyway, I put in an application to make them pay for my attendance at the Grassroots Falls Festival, and he wanted to know why he was paying for me to go to a music festival. Anyway, he's such a love. So, right, thanks so much for all coming. This is such a great turnout. I've always been despairing of the number of podiatrists who should be at the Grassroots Falls Festival, and I just think it's such an important space for us to be in. So I'm really enthusiastic about us becoming more proactive, because we're already doing so much in the space with falls. But I just think that we need to start doing a lot more like fishing. So falls is such a complex and multifaceted issue that I probably won't do justice to it.
See how that works.
Okay. Is that a bit better? Okay. So falls is a complex and a multifaceted issue, and so I won't probably do justice to the topic in my presentation, but we have put on a few other webinars, and we're happy to do some further stuff. So definitely give us feedback on any areas that you'd like us to go into more in more depth, and also if you want any resources, let us know and I can flick you through any papers or stuff that I've come across in my preparation for this. So Professor Keith Hill presented a webinar for us last year for Podiatry WA. If you didn't see it, look for it in the reruns that'll come out later this year. It was a really good introduction to falls, and I will get started. So older people make up a large and increasing percentage of our population. The economic burden of falls is significant and it's increasing, so it's a bit of a concern for our government. As they age, the risk of falls and consequent injuries increases. Also, a fall can be the first indication of an undetected illness. As I mentioned, we're already unofficially working in this space anyway. We just don't really put it under a falls banner. So we're assessing, we're diagnosing, we're treating, we're managing. So much of the stuff that I'll cover, much of the stuff that I'll cover, you'll be familiar with. But what more can we do apart from our regular routine care that can maximise our skills, our knowledge, and opportunities to provide a more comprehensive treatment to our patients? This workshop's designed to support podiatrists in screening, assessing, treating and managing patients to reduce the risk of falls. Unfortunately, most falls go unreported. Podiatrists, however, are in an ideal position to discuss falls with their patients. We see our patients on a regular basis, sometimes 6 to 8 times a year, and we have them in the chair for a long time, so we can have that conversation with them, and we can explore the subject. So even when falls are reported, the treatment of injuries resulting from a fall often doesn't include investigation of the underlying causes of the fall. So what can we do if, as podiatrists, if a patient tells us that they've had a fall? So I'd just like to have a show of hands. At the moment, who amongst us is confident, if they did ask their patients or they are asking their patients about falls, who's confident about assessing, managing and referring on if needed? Okay, all right, so you are in the right place today, because by the end of today, you're going to be so much better prepared. So for those 2 people that put their hand up, I'm sorry, you're probably going to be telling you everything you already know. Okay, many of the factors that that contribute to falls are modifiable. So this is where we can have a massive impact in reducing the rate of falls. So in my experience, there can be quite a difference between what the patient perceives is a fall and what technically is a fall. So trips, stumbles, accidental landings, falls with no obvious injuries, things like that can be shrugged off by the patient and not recognise them as a fall, and therefore they don't report it or they don't tell it. But also there's so much at stake for these older people who experience a fall, because the loss of independence, or the potential loss of independence, the loss of confidence, the embarrassment and the shame doesn't make them confident to disclose or report a fall, because the implications for them can be life-changing, really. The other thing is, and this is something that's fascinated me, and probably got nothing to do with today, but there's a profound difference between the age groups where someone falls over and where someone, usually older, has a fall. So anyway, that's something you can mull over. Now, as you can see, there's a huge list of risk factors for falls. Tony and I can talk about them in depth later on. I'll quickly skate over them. Basically, if you've had a fall in the past 12 months, you've got a much higher risk of having another fall. Age puts you more at risk of falls as well, but especially in the old women. I thought, was it the older women? That's the 85 plus. They're more likely to have falls. Foot problems we'll cover later in the presentation. Irrespective of what the medications are, if your patient's on 4 or more medications, that is a falls risk. And then, of course, it's, what kind of medications, but 4 or more, regardless of what they are, that's a falls risk. Chronic medical conditions, neurodegenerative disease, cerebrovascular, cardiovascular disease, COPD, depression, diabetes, arthritis, incontinence, these will all increase falls risks. From the age of 30, there's a natural gradual decline in strength, endurance and muscle power. This causes an eventual decline in function to the point that the patient is unable to prevent the slip or the trip or the stumble that becomes a fall, so they can't save themselves or recover. This is worse for patients who have been sedentary most of their lives. They lack the good balance or the righting mechanisms required to prevent a fall. There's another issue that is, it was actually a talk here last year, I think, on the fear of falling. So that's also known as post-fall anxiety syndrome, and that's a real problem because it's quite common, but after someone's had a fall, there's a restriction in activity that then, sadly, then increases their falls risk. So, but anyway, we can talk about that later, because that's a good conversation to have with your patient as well, or to be aware of it. Environmental hazards like poor lighting, slippery floors, uneven surfaces, rugs, mats, clutter. There's some good information in your handouts that talk about this as well. So we'll also discuss footwear later in the presentation. Falls risks are also increased when walking sticks and walkers are used that haven't been properly prescribed, fitted and the patient educated on the use of. I work in the Aboriginal community, and this is a real problem for us because they share all their devices, and even last week we had to swap someone's walking stick out for a walker because she'd given hers away to someone that she thought needed it more, and she was just a disaster waiting to happen. But anyway, I'll move on. So exposure to risk. Well, I think this one will say it all. Oops. Hopefully I can play it. No, you're not going to get to see it. Well, I think everyone wants to walk. Oh, what a shame. At the Grassroots Falls Festival, Sue Kitchen often presents, and she always puts disastrous videos up there for everybody to groan and cry and wince at. And I thought I'd do the same thing to you, but obviously you're going to be spared. All right, so getting down to feet. So the most common foot deformities in older people are bunions and lesser toe deformities. So it's all in the front of the foot, obviously. It's where most of the bones are. These deformities have a detrimental effect on balance and functional ability, and studies show that old people who fall are more likely to have these deformities than non-fallers. So older people with plantar callus and corns, they have greater difficulty walking on level ground and using stairs, and in tests of balance ability, they'll show a worse performance. Foot pain increases with age. Foot pain is a major risk factor for falls. I think one study showed about over the age of 65, 1 in 5 people will be suffering foot pain at the time. So it's linked to reduced quality of living and also reduced ability to perform activities of daily living. An interesting study found that for community-dwelling older patients with disabling foot pain, a multifaceted podiatric approach involving podiatry care, orthoses, footwear subsidy, foot and ankle exercises, falls education led to a Hello, that's better. It led to a 36% reduction in falls compared to patients who just merely received basic podiatry care. So those things that we're talking about is just our normal daily podiatry care. We're talking about footwear interventions, we're looking at orthoses or insoles, we're looking at, prescribing exercises. So I guess my biggest take-home message for today would be to make sure that you, as people get older, don't forget the impact that you can have by doing that full treatment for them. Okay. Now, ankle joint range of motion and first MPJ range of motion, as we know, they're important to gait because they provide the main sagittal plane pivots during propulsion. Ageing causes significant reductions in the range of motions of these joints. Ageing is also associated with reduced plantar flexion strength of the toes, and studies indicate older people generate 30% less plantar flexion strength in the toes than younger people. This is consistent with the declines in strength that I mentioned earlier of the lower limb muscles with advancing age. So fallers in one study had a reduction of more than 20% in their hallux and less toe strength compared to non-fallers. So this is something that we can measure in a kind of informal way, but I'll talk about that later. Hallux strength and lower extremity weakness is a predictor of falls. And fallers with diabetes have a higher prevalence of prominent metatarsal heads than non-fallers. That was a study that was looking at soft tissue thickness. Right, so moving along. So when it comes to gait, Tony and I might actually come back to this slide with Tony because we're going to do some practical stuff. But I think the most important thing is, as podiatrists, gait assessment is one of our strengths, and we are probably doing it unconsciously, if not formally. It provides us with a wealth of information, and this can make a big difference to our interventions. So I will skip over that one and get to the stuff that you need to know. All right, so you probably all know Hilton Menz. He's a podiatrist over in Victoria, and he's done a huge amount of work in this area of falls, but especially with footwear and the feet. And just last week, Podiatry WA did a webinar on intrinsic muscles of the feet with Melinda Smith. So there's some really good stuff coming out, and just keep an eye open for the rerun of that webinar as well later on this year. It was a good one. So footwear, as podiatrists, this is, well, I reckon it's a bane of our job, but it is a serious modifiable risk factor for falls, and it's an area that we can make a big difference in. So there's no surprises to hear, and tell me if you are surprised, that older people base footwear choices on perceived comfort rather than safety, with the majority of them wearing slippers at home, or the next popular choice is barefoot or socks. So that barefoot and sock wearing group have an increased falls risk in one study of up to 11 times compared to the ones that are wearing athletic or canvas shoes. So there's some really good information to support your argument when you're telling people to target what they're wearing at home. Most of the falls are happening in the home, so this is like an easy intervention. In one study, those who wore slippers indoors rather than no shoes or fastened shoes, they reported more foot pain and had a much higher risk fall score. In residential aged care facilities and hospitals, wearing slippers becomes more common, with up to 66% of people in one study wearing slippers. There was a strong association in a study found between wearing slippers as opposed to shoes and fractures. But there is conflicting evidence on the use of the non-slip socks, the grip socks type of thing. So if you want that kind of information, I can send that to you. Regarding fit, so there was a study that showed that up to 70% of older people, and when I say older people, I mean over 65 years old, in this study they found that these people were often in shoes that were either too long, too narrow, too wide, or so worn as to be beyond repair. Lack of a slip-resistant sole or a fastening mechanism, as well as flexible heel counters and shanks, were common. In another study, most of the older people were not wearing the correct shoe size for their foot. That was a big worry. The other risk factor that's been researched is walking outdoors in heels greater than 2.5 centimetres. That also increased falls. This was in comparison to the people that were wearing athletic shoes or canvas shoes. So we know that slippers or shoes without fixation increases the risk of tripping types of falls. This is aggravated if the heel counter is excessively flexible and the sole excessively soft. So this goes back to patients that are choosing comfort over safety. They'll go for like a soft, squishier type of sole. Slip-on shoes and sandals are associated with a greater risk of foot fracture from a fall, and wearing medium to high-heeled shoes and narrow shoes increase the risk of fracture at 5 sites through the body in a study of people over 45 years old. And I will go back to that younger group, the 45 to 50-year-old group later on. So, what's the evidence? Well, the evidence would support people having their feet measured for fit. Poorly fitting or excessively worn shoes can play a role in falls in up to 50% of falls. So that's a really easy fix, is just getting your patients to have their feet measured. So through Moritz Jenner now, when we are doing footwear referrals, we're actually putting that as one of the requirements, is that the feet have to be measured. And it can happen at some of the specialist shoe shops that your patients are going in there and they're not actually having their foot measured on that Brannock measurement device. So I've actually added it into our requirements. The other thing that we know is increasing the sole surface area. A lot of this is just common sense, but I wanted to let you know where the evidence was at with this. So they found that the risk of fall significantly decreased with an increase in the sole surface area above 74 centimetres squared. So how much is that? Well, high heels have a median sole surface area of about 49 centimetres squared. So that gives you a bit of an idea. They need to be quite a lot wider and broader from the sole than your high heels. The other research was, we've already mentioned it, the lack of fastenings increased the tripping and also fractures. This was a study done by Hilton Men's with the slips and the soles. The heel geometry will also influence slip resistance. So at the back of the shoe where the heel is, he found that a beveled heel of about 10 degrees posteriorly made a difference. And all that means is that you don't have that sharp pivot point when the heel hits the ground. If you do have a patient who happens to be striking on the heel, having a beveled area there gives them a lot more stability and reduces the risk of falls. This is especially so with shuffling type gaits. So I did mention the thick soft sole material, which people tend to instinctively go when they're looking for comfort. Shoes with soft thick soles impair stability. They reduce joint position sense. It's also possible that they threaten older people's stability because there's greater muscular activity required to maintain stability in stopping. There's I didn't find much evidence to support high collars in shoes. They have looked at it, but I think they did find that it did reduce some postural sway. So you can look at that paper if you're interested. Now, there has been some work done on stimulating the plantar tactile sensitivity via insoles. So this is an interesting new space, and they do it either mechanically by the surface of the insole or with vibration. And this is to kind of stimulate and help postural control. There has been some evidence that this does improve balance, but I wasn't able to find consistent results.